Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Christopher McCrum from Dallas, Texas. Dr. McCrum is an assistant professor in the Department of Orthopedic Surgery at the UT Southwestern Medical Center. He obtained his bachelor's degree in movement science from the University of Michigan, and he earned his medical degree at the Case Western Reserve University School of Medicine. Subsequently, he completed his orthopedic residency at the Los Angeles County Hospital and Keck Medical Center at the University of Southern California. He then received advanced training in sports medicine through a fellowship at the University of Pittsburgh Medical Center. His research interests include joint preservation and cartilage replacement, stem cells, shoulder and knee surgery, and return to play outcomes in elite athletes. He's also a reviewer for a number of sports medicine publications, and he serves on the editorial board for the Arthroscopy journal. Today, it's my great honor to introduce you to Dr. Christopher McCrum from Dallas, Texas. Over to you, Chris.
Thank you very much for the introduction, and thank you for having me. I'm very excited to give a quick little talk on cartilage repair of the knee joint. So I'll kind of get started. Here are my disclosures. It doesn't influence anything I discuss during this talk. So we'll start off with a brief overview of cartilage biology for the sports medicine surgeon. This includes molecular biology, cartilage biomechanics, and the mechanism of cartilage injury, particularly in the context of focal cartilage injuries. So general overview of the articular cartilage structure. Water is about 75% of the cartilage weight, and it's found more commonly in the deep area of cartilage, where it helps give compressive resistance to stress. You have a lower concentration of water in the more superficial areas of the cartilage. The cell type of cartilage is the chondrocyte, with a highest density in the superficial layer of the cartilage. And the density decreases as you go deeper in the cartilage. In fact, deep, you have about a third of the cartilage density compared to what you would find in the superficial cartilage. The cartilage cells itself secrete the cartilage matrix, which has the most common substance of type 2 collagen. That's important when differentiating reparative type collagen versus reparative type cartilage versus more natural articular cartilage or hyaline cartilage, which has type 2 collagen, versus the repair tissue tends to be more commonly type 1 collagen. The structural organization is critical to restoring and providing the function of the articular cartilage. Superficially, the cartilage has flat chondrocytes that are parallel to the surface. This is important because it's aligned to help resist strain and translation across the actual articulation. As we go deeper, the collagen becomes a little bit more oblique, and it's more poorly organized in the intermediate zone versus the more deep zone of the cartilage. But as we get into the intermediate zone, this is an area where the chondrocytes become more round. The deep cartilage has the chondrocytes are lined up in columns in the collagen, and the chondrocytes are quite round. And below this is where you have the calcification of the cartilage and the tide mark zone. And this is important when you consider healing, because cartilage is isolated from the blood supply. So it's avascular. So below the tide mark zone is where we have the marrow elements. As far as the type 2 collagen itself, this is about 90 to 95% of the collagen of articular cartilage. It's about 10% of the wet weight. And importantly, it's highly cross-linked and interconnected. And the way that this is organized is through these aggregating proteoglycans. So the most common of these is aggrecan, which is a highly glycosylated protein along with glycosaminoglycan side chains. These include the sulfate groups, which have a very large negative charge. And these aggrecan molecules have a high affinity for hyaluronic acid and link protein, which leads to the aggregation of these molecules. Hyaluronic acid is a large unbranched polysaccharide, and this is what is able to help bond these aggregan molecules together to form the large aggregates. Decorin is another critical component of the articular cartilage matrix, and this helps preferentially bind the thicker collagen and also fills the gaps between these aggregans. And what we see in histologic studies is in areas of mechanical stress, decorin is upregulated because it helps bind these groups together to help provide some of the structural integrity of the cartilage. As to the biomechanics, the high negative charge that we have on the aggregate molecules increases the osmolality of the substance, which means that it's going to attract water. As a result, you'll have a high tissue pressure, but you have a strong cartilage matrix with a type 2 collagen that's got very distinct organization that prevents the tissue swelling. This high volume of water and high tissue pressure gives resistance to compression. During mechanical loading, this is what actually helps modulate nutrition as the articular cartilage and chondrocytes derive their nutrition from the articular fluid. When you have a load, that leads to the compression of the cartilage, and the cartilage matrix and interstitial fluid is expulsed from the tissue itself, and that helps get rid of the tissue metabolites from the chondrocytes. Although it's important to keep in mind that the metabolism of chondrocytes is relatively low compared to other cells in the body. During unloading of the cartilage, or when you take axial stress off the cartilage, the nutrient fluids from the synovial fluid can then diffuse into the matrix. So this is how loading is actually healthy for cartilage. So it's a little bit counterintuitive because a lot of patients particularly think that cartilage wear is like tire wear, that the more activity that you do, the more the cartilage wears down. It actually is the opposite. Loading is actually healthy for the cartilage, and it helps nourish the cartilage when you have normal physiologic loads. This also helps stimulate the matrix production, particularly with fluctuating loads. However, if you've got just a static load, this decreases your aggregan and link protein synthesis. So this is something that we start seeing in osteoarthritis or people with malalignment of the limb, where you might have just a static load in a small area of an articulation. As we talked about, the nutrition is avascular, and it's through diffusion of the synovial fluid. The chondrocytes are the ones that secrete the matrix components as well as the degradative enzymes. And this is regulated by growth factors and cytokines via surface receptors. Briefly, the big players in this game, as far as growth factors go, we have TGF-beta, which is chondroprotective. It helps increase collagen production and proteoglycan synthesis, as well as inhibit matrix degradation and cell proliferation. IGF-1 has similar function, and it also is a key player in the response to the mechanical stimulation that we discussed a moment ago. BMP, or bone morphogenic proteins 2 and 7, also help stimulate the production of proteoglycan, as well as they help maintain the articular chondrocyte phenotype. So that's as opposed to something like fibrocartilage. Catabolic enzymes, a big player and a hot topic now in research, are matrix metalloproteinases, as well as interleukin-1 and TNF-alpha. These are degradative enzymes, so upregulation of these substances often occur during joint injury, and they result in a net degradation or removal of the articular cartilage. Important to consider in context of articular cartilage is also the subchondral bone, as this gives the support network for the cartilage itself and is critical when we start thinking about what to do in the context of cartilage injury and repair. The cortical end plate is what's immediately deep to the calcified articular cartilage. Again, this separates the articular cartilage from bone marrow. Collagen transitions from type 2 to type 10 in the in the calcified cartilage. And most common collagen in the subchondral bone is obviously type 1 collagen, as is the case in any bone. This junction between the calcified cartilage and the bone is biomechanically weak, and it's potentially area for failure. The subchondral bone itself supports the articular cartilage architecture, and it helps transition and transmit the force from the cartilage itself to the bone. If you've got an abnormal subchondral plate, this is going to lead to abnormal force transmission, and it's going to lead to increased levels of force that are transmitted through the articular cartilage itself. Early studies on the subchondral bone itself and injury to the subchondral bone suggests that the bone itself does not regenerate and replenish the normal surface anatomy. Instead, it tends to become sclerotic, and you can have aberrations of bony growth that can actually lead to interlesional osteophytes. The bone itself is very sclerotic, and the repair cartilage tends to be fibrocartilage or disorganized cartilage that has predilection to be type 1 cartilage or type 1 collagen based, as opposed to the type 2 collagen that we find in articular cartilage. And the normal architecture of the cartilage is not the same, which means that it's poor, particularly at resisting shear stresses. As far as the natural history of cartilage lesions goes, this is actually a very poorly studied topic. The earliest studies on this, kind of the landmark study, was done by Dr. Shelbourne in JBJS, where he looked at patients with ACL injury and the influence of articular cartilage injury in those patients as they went forward. And he found that the full thickness or grade 3 to grade 4 cartilage injury did not influence patient outcomes going forward, and lesion size didn't even play an impact into it. Further study, though, suggests that these injuries may progress. It's difficult to predict who will have a progressive lesion, however. As far as the injury itself, it can either be a single severe or repetitive blunt impulses. Trauma leads to chondrocyte apoptosis, and this has been shown in multiple histologic studies, mainly in animal models. Up to 34% of the chondrocytes can go through apoptosis or cell death as a response to this cell injury due to trauma. Visually, so if you were to do an arthroscopy immediately after an injury, this would not always be immediately apparent, as I'm sure most of you know. The cartilage matrix itself may remain intact, and only over time would you notice that the absence of the chondrocytes would lead to decreased matrix formation and damage to the cartilage going forward. In the context of a chronic repetitive load, you can get cartilage softening, or this is type 1 chondromalacia, which can lead to fissuring and tears and delamination of the cartilage. Specifically, an area of the cartilage that's important to note with regard to this is the lamina splendens. It's named this due to its appearance on light microscopy that it tends to enhance. It's the most superficial layer of the superficial zone of the cartilage, and has actually some progenitor cells that have differential potential to potentially differentiate into chondrocytes. This is kind of the skin of the cartilage, and removal of the cell layer leads to increased permeability of the cartilage, which increases the macromolecular loads on the framework, and may be the earliest sign of cartilage damage. You can see in this little image here that with the violation of the subchondral plate, that's where we get the release of both growth factors as well as cytokines, and that leads to the creation of reparative tissue. Counter to that, if you just have injury to the cartilage, either microdamage or chondral fracture, this leads to wear of the cartilage without the generation of reparative tissue. If you've got a focal area where the cartilage surface geometry is damaged, this leads to abnormal load concentration at the periphery of the lesion. Of note, this is both on the side of the lesion itself as well as the opposite side of the joint. So for instance, if you've got a cartilage lesion on the femur, this is also going to lead to increased strains in focal areas on the tibial side or the patellar side of the joint. This area of edge loading tends to become more relevant in bigger lesions. And this is because the bigger gap in articulation in the middle of the lesions lead to increased levels of force that are generated on the peripheries of the lesion. The clinical relevance and course of this is unclear, and as we discussed before, this is actually fairly poorly studied in the literature. As far as the grading of the articular cartilage goes, there's two main classifications: the more historical and simple classifications, the Outerbridge classification, where grade 0 is normal. Grade 1 has softening and swelling of the cartilage. Grade 2 is partial thickness defect, and it can include fissures on the surface that don't reach the subchondral bone. Grade 3 is fissuring to the level of the subchondral bone, but not through the subchondral bone. And grade 4 is just exposed subchondral bone. And this is something that's done at the time of arthroscopy. ICRS is a newer grading system that has a lot more capacity for detail. Grade 0 is normal cartilage. Grade 1, we've got nearly normal cartilage that may have either a soft indentation or superficial fissures. Grade 2 is less than 50% cartilage depth loss. Grade 3 is severely abnormal with cartilage defects either extending 50% through the cartilage as well as down to the layer of the calcified cartilage. B is down to but not through the subchondral bone. And grade D is blisters in the area as well. Grade 4 is severely abnormal with bone loss. And the nice thing about the ICRS grading is this also includes a way to classify the size of the lesions as well as the location of the lesions. And this is helpful for research as it would also include data on meniscus status in addition to the size and location of these lesions. As far as the epidemiology of cartilage lesions, it's actually very, very common, particularly in patients who undergo knee arthroscopy. In all comers, it's about 5 to 10% of patients who are over 40 years old will have some level of articular cartilage injury. In those who undergo knee arthroscopy, this can be up to 60 to 65% of patients are found to have lesions, 41% of which are outer bridge grade 3 and 19% of which are outer bridge grade 4. Only a small fraction of these are what we would consider to be more clinically relevant or bigger than 2 centimeters squared in size. These lesions, however, are much more common in athletes. Full thickness cartilage lesions are proposed to be found in about a third of NBA and NFL athletes, so professional basketball and professional American football. That being said, of these lesions, up to 14% may be asymptomatic. We'll move on to cartilage repair, and the main topics we'll discuss with the cartilage repair itself will be marrow stimulation, as well as scaffold augmentation of marrow stimulation, allogenic and autogenous minced cartilage, autologous chondrocyte implantation, as well as osteochondral grafting. So brief overview. So what is cartilage repair? There's many different factors to consider, and Borelli et al. Have a nice little diagram to consider the factors that we need to consider with tissue engineering when it comes to articular cartilage. So with regard to cells, you want to think about autogenic cells, allogenic cells, or mesenchymal stem cells. We have bioactive substances, so that's what you would get from your marrow stimulation, as well as things like platelet-rich plasma, bone marrow, concentrate or BMCs, and then scaffolds that we'll talk about later. And those are things that could be meshes, composites, woven fibers, hydrogels, things like that. So these are all things that play into tissue engineering with regard to cartilage repair. Historically, the most common procedure had been chondroplasty, where essentially the arthroscopist or sports surgeon would remove any mechanical impediments to motion. However, this is found to have inferior outcomes to even just marrow stimulation alone, and is really only indicated now for low-grade cartilage injury that is generally less than 50% cartilage thickness or very small lesions. Marrow stimulation is kind of the preferred terminology over microfracture. Marrow stimulation differentiates because it can either be microfracture, which is what we historically think of with using an awl to create holes in the bone marrow to allow a fusion of marrow elements into the lesion, but also subchondral drilling, which is becoming more popular. Newer technology are restorative procedures. So things like Microfracture Plus, so this is the scaffolds in addition to the subchondral drilling or marrow stimulation, autologous chondrocyte implantation, and osteochondral grafting. Epidemiology of cartilage repair. So if you review the US registry, this is about 7.8 per 10,000 patients undergo some sort of cartilage repair procedure. Again, chondroplasty is most common, but it's rapidly decreasing if we look at the data over time. Microfracture is the most common procedure after this, and it's becoming the most common procedure overall. Restorative repair is only about 34 to 1, so much less common than things like microfracture or chondroplasty. In the German registry, autologous chondrocyte implantations, the most common restorative procedure, particularly in the patellofemoral joint. Mirror stimulation and OC allograft are used for smaller defects in their population, whereas ACI is used more commonly in the larger defects. So just to briefly talk about a potential repair algorithm. So it's always helpful to think of an algorithm when you're trying to come up with treatment options for individual patients. I think the most important characteristics to think of when we think of cartilage lesions are the patient themselves. So you want to make sure that they don't have unaddressed comorbidities like meniscal insufficiency, malalignment, ligamentous insufficiency. You want non-smokers ideally. And you want patients who are compliant. Relative contraindications being age and BMI, I think those are relative at that. If you've got a very healthy 60-year-old with otherwise healthy articular cartilage, healthy meniscus, appropriate alignment, they might be a good candidate for joint replacement. Same if you've got an athletic, heavier patient, particularly in the US, we've got the American football players who often have higher BMIs, but are candidates for some of these restorative procedures due to their high demand nature. When you think about the lesions themselves, we want to consider size as well as it's cartilage alone or cartilage and bone that are effective. So as far as size of the lesion goes, historically the number has been 3 centimeters squared. But I think if you look at the literature now, where things are going is we start to consider a larger defect to be about 2 centimeters squared even. As far as making treatment decisions. In my practice, I generally use about 2 centimeters squared or larger to be considered a large defect. When we start thinking about small defects, if you've got chondral only defect, we can think about things like marrow stimulation with or without scaffolds, with or without juvenile particular allograft. And if you've got an osteochondral lesion, or even if you've got a chondral only lesion, you could think about something like an osteochondral autograft. Whereas if you've got a large lesion, we think about things like ACI scaffolds and the juvenile particular allograft for cartilage only lesions, whereas a bony lesion will require either an osteochondral allograft or a bone grafting procedure in conjunction with autologous chondrocyte implantation. So to talk more in depth about these specific procedures, we'll start off with microfracture or marrow stimulation. So this was most earliest described by Stedman. Essentially, the concept of this is to allow for marrow elements to fuse into the defect in order to allow for the formation of reparative tissue, as we kind of discussed earlier on the biology of cartilage repair. Unfortunately, with microfracture or marrow stimulation alone, we tend to get type 1 collagen based repairs, and it's more disorganized and it's structurally weaker, particularly with regard to shear stress. And as a result, this leads to relatively rapid failure of this reparative tissue. It doesn't heal again because after you get the effusion of marrow elements, this eventually stops. So there's no more stimulation of tissue. So when this tissue has worn away, generally over the first couple of years, there's no reparative tissue after that. There are substantial benefits to this, particularly the cost. It's inexpensive. It can be done in a single stage, and it can generally be done arthroscopically. Unfortunately, this does poorly, particularly in larger defects, so bigger than 2 to 3 centimeters squared. As far as the actual numbers on durability, you've got about a 2% failure rate at 2 years, and this can be up to about 40% at 10 years. The prognostic factors that might suggest a lower rate of success are patients who are smokers, who are obese and have a longer symptom duration. And also we can see on MRI if they've got poor fill of the lesion or poor quality of tissue. If we look at like degeneric MRIs, if they've got poor histologic tissue noted on the MRI, these tend to be poor prognostic factors for marrow stimulation. At 15 years, about 50% of patients who undergo microfracture are found to have osteoarthritis. However, it is significantly better than chondroplasty alone, as we mentioned earlier. Fill of the lesion is a very important factor with regard to ultimate outcome. Depending on the study you read and depending on the technique, you're going to find a wide variation in reported fill rates, anywhere from about 20% of patients to 95% of patients, with poor fill rates anywhere from 17 to 60%. So this is, enough all over the map that I think it's difficult to predict with the literature. I think one thing you will find, particularly within Stedman's research on this is patients who undergo strict range of motion after surgery with continuous passive motion and have a very strict rehabilitation protocol tend to do a little bit better than those who don't have as strict of a protocol. And what we find is patient-reported outcome and function tends to be pretty well correlated with the reported fill rates. One issue with microfracture, which I'm sure many of you have seen, are bone overgrowth within the microfracture lesion itself. And this tends to be associated with overgrowth and injury to the subchondral plate itself. And this can be, again, very widely reported in the literature, from as low as 10% to up to nearly every single case can have some degree of bone overgrowth. However, the studies that report very high rates of overgrowth, so greater than 60 to 99%, these tend to be very low grade and small areas and tend to correlate with the small areas of the actual microfracture themselves. And it might not preclude necessarily good fill rates. Large lesions tend to have a higher incidence of these intralesional osteophytes, and it's associated again with the violation of the subchondral plate. Another poor prognostic factor for having these bony overgrowth is obesity or BMI greater than 30 to 35. And that may be due to the dramatic increase in loading in this area, which may stimulate the need for more robust tissue than just the fibrocartilage alone. The important thing to look at with this is patients who have the bone overgrowth, you have a 10 times higher failure rate of their microfracture. So if you see this on radiograph or MRI, this is kind of a red flag of a patient who has a high risk of failing this procedure. As far as technique goes, what we discussed earlier on marrow stimulation versus microfracture, my preference is to use either a proprietary device or a 1.5 millimeter K-wire under either lavage or arthroscopically to create my microfracture. There's a couple of reasons for this. The main reason is, as you can see by this study by Chen, when you use a microfracture what can happen is you can cause impaction of the surrounding bone, which may inhibit your marrow from effusing into the lesion, versus the drill hole itself will not do that. You'll actually be able to get a little bit more marrow effusion. The second reason, just from a technical standpoint, it's much easier to control the drill to prevent your microfractures or your marrow stimulation holes from fracturing into each other. So as far as other technical pearls with microfracture, it's critical that you remove the underlying calcified cartilage layer. This is going to also prevent adhesion of these effused marrow elements, and this is going to prevent the nutrient diffusion in this area as well. So this is, in addition to that, you want to always make sure you have about 90-degree walls, which will contain the clot itself from the effusion of the marrow elements. So technique is very critical in achieving a good outcome with marrow stimulation. Laprod's group, led by Decker, recently published a very nice study that went through a lot of the cartilage repair techniques and summarized the recommendations, advantages, disadvantages, and level of evidence in the literature. Essentially, their conclusion was for the marrow stimulation, this is indicated for lesions less than 2 centimeters squared, grade 3 to grade 4 cartilage, and there's a grade B level recommendation for this. And you can see what the advantages and disadvantages as well as indications and contraindications are. You can see that their group as well recommended drilling to limit the damage to the subchondral plate. We'll move on to different augmenting options for microfracture, and these are things that we can consider microfracture potentially for larger lesions. Now, the big downside to a lot of these products is cost. This is going to add significantly to the cost of any microfracture procedure. So I think it's important to understand what the literature is before we move forward too far with just adding these to every single microfracture procedure, particularly because, as you'll see, much of the data on this has not been flushed out very well, and there's particularly a paucity of long-term data on a lot of these things. So the first thing we'll talk about is cartilage matrix scaffolds. Several different US and international companies offer products. Essentially, the thread that links these all together is they've got type 2 collagen, the proteoglycans and growth factors that we mentioned earlier, And the way that I like to discuss this with patients is it's like you're bringing the appropriate high quality material for the contractor to build a more high quality result. So what we've seen in the early studies with tissue biopsies as well as with animal studies is that the augmentation of these lesions these microfracture with the cartilage matrix scaffolds is we get more hyaline-like cartilage. So we see a higher percentage of type 2 collagen. We see more organization than we would with just microfracture alone. As far as the early clinical outcomes, there's significant improvement in pain and on the visual analog scale that holds for 2 years. And there's a relatively low failure rate, reported to be about 4% in the early literature. The big downside to a lot of these studies is we're not comparing this to microfracture alone. We're not comparing these to kind of a control group. With all of these, particularly these matrix and these augmentation studies, I think a lot more literature needs to come out before we kind of, as a society, move forward with all of these again in a general basis. Another technique is an osteochondral allograft. So this is a cryopreserved perforated osteochondral allograft. This is available in the US and also several other countries abroad. The advantage to this product is there's viable chondrocytes in the graft itself. So this is actually created from a fresh osteochondral allograft. You've got viable chondrocytes that are preserved and they remain greater than 90% viable 2 years. And the advantage to this is it's single stage and can be used in conjunction with marrow stimulation. The graft itself is flexible and it doesn't, outside of the marrow stimulation itself, it doesn't damage the subchondral architecture any further than just a microfracture by itself would. However, again, there's minimal long-term outcome on this. There's a small case series that follows uni and bipolar patellofemoral defects. When this study, they have a relatively high reoperation rate, about 20% at 2 years, as well as a high failure rate. There's a couple other small case series that don't show this high reoperation and failure rate. But also, again, there's no control group. There's no good long-term evidence to support this. This MRI scan, you can see the preoperative image where you've got a delaminated cartilage lesion and the postoperative image where we've got restored cartilage. So this shows the potential for a product like this. Another product is allogenic juvenile minced chondrocytes. In the US, this is a product called De Novo. These are basically minced articular cartilage fragments from a juvenile cartilage donor. Again, mainly short-term results on this type of data. Again, it's a single stage procedure. And there's histologically, you get similar hyaline-like cartilage on MRI as well as on cartilage biopsy, where you have a predilection for type 2 collagen over type 1 collagen. There's much more evidence on the juvenile minced chondrocytes than the previous couple of products. And it does show improved patient-reported outcomes in MRI filling, particularly in the patellofemoral joint. The one big downside to this is about a third of the cases did show graft hypertrophy, so a really robust response to cartilage regrowth. And this can require debridements due to increased joint reactive pressures in the area where you do have the graft hypertrophy. So again, from the LaPrade article, they recommend the particulated juvenile allogenic cartilage for lesions between 2 and 6 with centimeters squared with outer bridge grade 3 to 4 chondral loss, but intact subchondral bone. An important thing to remember with this is this does not require microfracture, so you actually can keep the subchondral architecture. So this might be a nice single stage procedure if you don't want to damage the underlying subchondral architecture, which is important when we consider other procedures and their failure rate. Particularly, autologous chondrocyte implantation has a significantly higher failure rate in patients who have had microfracture done in the past. As far as single stage autologous chondrocyte implantation, this is in preclinical stages. Particularly in the US, this is not an approved product. Essentially, what these authors are trying to investigate is if we take chondrocytes alone instead of chondrocytes and bone in areas that we would harvest osteochondral autograft plugs, so the notch, areas superior to the sulcus terminalis on the lateral femoral condyle. If we take some of those cartilage cells, mince them, and implant them into lesions in a single stage, along with potential biologics to see if this would help fill lesions. This is something that I think holds potential because we know these cells are viable, but this obviously is going to require quite a bit of study to determine if it's something that's worthwhile to move forward in practice. The advantage to something like this is it may be a lower cost than other off-the-shelf products as well as a single stage. So just technical pearls or things to think about with regard to some of these microfracture plus techniques or single stage techniques. It's critical to prevent dislodging of these grafts in the operating room or immediately post-operatively. So ways to do this, so 90 degrees walls is critical. So you want to make sure your lesion is contained. You want the walls to be 90 degrees to be able to hold whatever product that you're putting in, including the clot that's ultimately going to form post-operatively. Again, the calcified cartilage layer needs to be completely removed, which is going to help with both clot adhesion as well as diffusion of nutrients. You don't want to leave the graft proud or the glue proud, as this will lead to increased friction and strain in this area, which may lead to dislodging of the graft. Additionally, it's important, a lot of these products require fibrin glue to be used to put over the graft itself to help contain the graft in a 360-degree fashion. It's important to make sure that the fibrin glue itself is dried so that it doesn't adhere to the other side of the joint. In my practice, I tend to immobilize the patients for 3 to 5 days post-operatively in order to allow for this lesion to become a little bit more stable to prevent dislodging of the grafts. Additionally, if you're using one of the products like the cryopreserved allograft, you can consider putting a suture anchor in to give yourself a little bit more stability, particularly if you have not a completely contained lesion. All right, so moving on to autologous chondrocyte implantation. So the history of ACI or autologous chondrocyte implantation. So the first generation chondrocytes were biopsied and cultured outside of the body for several weeks. And a second procedure was done and they were implanted under a periosteal flap that was often harvested from the proximal tibia. While the patient-reported outcomes and general fill of these lesions tended to be quite good, there was a high predilection again for hypertrophy or overgrowth of the cartilage. The second generation of ACI, we replaced the periosteal membrane with collagen 1 and 3 membranes. And these tend to have a lower rate of the hypertrophy and overgrowth of cartilage. Third generation, the cultured cells themselves are implanted on the membrane. One important thing to remember, particularly in the US, is this membrane is derived from porcine peritoneum. And there are patients who would decline porcine products, generally due to religious or philosophical priorities. So it's important to educate patients that, particularly in the US, our one FDA product is derived from the peritoneal membrane. The reason that this was selected, and it's the same thing as the synthetic membranes, is it's got a porous side to allow for cell infiltration and a non-porous side that allows for the cell retention. So this is ACI, this is a second generation ACI picture. So cell therapy with the goal of forming hyaline-like cartilage. What's done technically is we harvest articular cartilage from the non-critical areas where it's sent to a lab and expanded in culture, and the chondrocytes are released from the matrix and expanded in this culture. These are then sent back to the surgeon and the patient's brought back to the OR, and the periosteal patch is attached to the surrounding cartilage with good walls. The benefit to this is it does give you more hyaline-like cartilage than microfracture, and it can address larger defects. The limitation is you should have full thickness margins around the defects, and it's 2 stages. Additionally, the cost is quite high, and particularly first and second generation, you must protect the weight bearing. The big advantage to the third generation or MACI, matrix associated ACI, is that the cells are attached to the membrane. So this has two big benefits. Technically, it's much less challenging because you don't need to sew the membrane itself to the surrounding cartilage. And it also allows you to initiate weight bearing earlier and be much more aggressive with your postoperative rehabilitation protocol, which means patients have the capacity to fully recover quicker. Again, limitations, big limitation is cost, as well as the fact that that is a two-stage procedure. As far as the tissue itself, you get hyaline-like cartilage in 50 to 75% of the graft area. The newer studies compared to what was done historically have a higher percentage. So the 50% hyaline cartilage reports are the earlier studies. The newer studies tend to be reporting a higher percentage of hyaline cartilage. This tissue actually forms fairly quickly. As early as 6 weeks, we start to see more hyaline-like organization of the cartilage with the MACI repair tissue. And this holds at 2 years after surgery. So a big question is, a lot of innovation has gone into evolving autologous chondrocyte implantation, but there's little comparative data between the historical studies and the newest technology, or MACI. And the studies that we do have of any of these studies tend to be shorter follow-up duration. So a recent meta-analysis concluded that second generation has marginally better clinical outcomes than first generation. And it tends to be particularly associated with graft hypertrophy, as well as lower rates of intra-articular adhesions and delamination of the graft. Again, these studies also, again, early follow-up, but you have the early weight-bearing advantage with the MACI over the second and first generation ACI. Clinical outcomes, there's a substantial number of cohorts and randomized control trials of ACI and MACI. And there's really a copious amount of literature, particularly compared to these Microfracture Plus that we were talking about earlier in this discussion. In general, there's a significant patient reported outcome improvement, as well as a low reoperation rate. Small lesions have negligible difference when you compare them to marrow stimulation alone, particularly in the short term. Large lesions where we really see the benefit for MACI. The failure rate is about 9 to 10%, and these tend to be higher in the tibiofemoral joint versus the patellofemoral joint. And this, MACI in particular and ACI in general is really desirable in the patellofemoral joint due to the significant differences in morphology of anatomy between individuals. It's often very difficult to get good surface contour match for osteochondral grafts in this joint. So particularly large lesions in the patellofemoral joint, not only do they do better with MACI, but also technically it tends to make things much easier, and it makes, graft selection is not a big challenge for these patients because you will be able to conform your repair to the patient's anatomy. A critical thing to remember with MACI, particularly if you're seeing a patient for the first time, if they've got a large lesion, you may not be doing the patient a favor to microfracture them. Particularly since all these patients have to undergo a cartilage biopsy. Historically, we thought, hey, maybe we can do a little bit of marrow stimulation. This may help prevent a second surgery or may help the patient in the interim. However, if you look at the studies, what we see is those patients have a higher failure rate and lower patient-reported outcomes than those who just have a primary MACI alone. My recommendation for the biopsy procedure is to only do a chondroplasty of the lesions where you plan to do MACI in the future in order to avoid having this decreased sealing and outcome and higher failure rate. And again, MACI, we're depending on the subchondral plate to give our foundation for repair. Now, this technique can be done in patients who have a violated subchondral plate, but you do need to do what's called a sandwich procedure, or you need to do subchondral bone grafting to restore the subchondral anatomy. So it becomes a more complex procedure. So technical pearls, again, if you've got a partially uncontained lesion, this is considered to be a relative contraindication to ACI. However, with MACI or ACI, you can use, again, a suture anchor and just attach and secure that lesion so that the cells can be contained in the lesion. My personal preference is to use a knotless anchor in this region with a non-absorbable suture. You could also use absorbable sutures if you want to tie knots. You also, again, want to prevent the grafts from dislodging. So again, critical technique, 90-degree walls. With MACI, this is basically you apply a fibrin glue to the base of the lesion after removing the calcified cartilage, and then you apply a firm, consistent pressure over the entirety of the graft. So after you apply this pressure generally for about 5 minutes, you want to really carefully investigate the graft to make sure that you've got good adhesion of the graft and there's no areas where you don't have adhesions that may delaminate after you leave the OR. So again, going back to the article by Decker and Laprade, they recommend this as a first-line treatment for defects bigger than 2 centimeters square with grade 3 to 4 outer bridge lesions, or as well as a second-line treatment for a small lesion. Again, grade B recommendation. So moving on to osteochondral lesion repair. We've got osteochondral allograft and mosaoplasty, or osteochondral allograft and autograft and mosaoplasty. The advantage of these techniques, chondrocytes remain viable. They're single stage and you can do immediate range of motion. It's inexpensive with the autograft. The limitation is donor site morbidity. These lesions tend to fill with fibrocartilage. So the autograft itself, you want to harvest proximal to the medial sulcus terminalis. This is the lowest joint contact pressure. The next best area is the lateral aspect of the trochlea. Compared to the other cartilage repair procedures, it has more hyaline-like cartilage and better patient-reported outcomes. The big limitation is the graft morbidity. About 2 to 13% of patients complain of anterior knee pain and crepitus. You may want to consider filling your donor site with the recipient site plug. This is a nice study comparing mosaoplasty compared to microfracture in athletes. And you see that there's a much lower failure rate in athletes compared to microfracture postoperatively. So again, grade B evidence for small lesions for osteochondral autograft. Osteochondral allograft is another option. We'll talk briefly about the graft preservation, chondrocyte viability, rejection and immune response, as well as the actual mechanics of the graft itself. The nice thing about osteochondral allograft is you can repair the cartilage defect with live chondrocytes in a mature matrix. You can also restore the underlying bone. Grafts themselves are fresh. They're preserved in a solution generally for 30 to 52 days with good chondrocyte viability, depending on what the solution is. Again, this can address very large lesions. The big downside is cost as well as graft availability in the US. This can be up to or more than $30,000 per graft. There's also a risk of infection and immunogenicity. As far as survival goes, about 95% at 5 years and about 60% at 25 years. So this is actually quite excellent. Return to sport for osteochondral allograft is about 75% at the same level. Professional athletes have been reported at about 80%. About 75% good to excellent outcomes at 12 years. As far as technique, you want to make sure that you do not leave these grafts proud. You can see even a small amount of proudness, so 0.5 millimeters proud is going to significantly increase the contact force of the graft itself, both in the medial compartment and lateral compartment. As far as contour match, however, I think it's important to know that you can use a lateral femoral condyle graft to repair a medial femoral condyle defect, and often you can match adequately the surface contour to an acceptable level. There have been several studies. This one in particular has shown that this is an acceptable treatment. As far as the immunogenicity of the grafts themselves, this is a proposed failure mechanism, but it's poorly reported. In the literature, we found that there's mainly class 1, but also class 2 MHC responses to this. Poorly described in the literature, so it's difficult to describe what the actual failure rate is. Pulsatile lavage is technically what we do to try to get as many of the marrow elements out of the grafts themselves, but particularly larger plugs, which is what we're doing osteochondral allografts. We have difficulty removing 100% of the marrow elements. So theoretically, this is a possible means for failure for any of these grafts. Definitely need more studies to see the clinical relevance as well as what can be done to better minimize this risk. Cost itself, I'll briefly skim over this. Essentially, there's been a couple of cost analysis that despite the high cost of this, it tends to be cost effective as it may prevent things like knee arthroplasty. This is a case example, preoperative, postoperative arthroscopy at a year, nice restoration of the medial femoral condyle architecture. So briefly, impaction of the graft. So these grafts are generally press fit, but impaction of graft does lead to chondrocyte cell death. There's significant decrease in viability with impaction of the graft, but this does normalize at about 8 days postoperatively, and it doesn't affect the matrix itself. So an insertion pearl, you want to take advantage of fluid and hydraulic mechanics. So you want to drill the recipient and donor sites with the K-wire in order to prevent the hydraulic pressure from preventing you from seeding your graft. This is also an option for osteonecrosis. About 37% of patients who require chronic corticosteroids end up having osteonecrosis of the knee joint. Definitely a higher risk with higher doses of steroids as well as with lupus. There's a paucity of evidence on osteochondral allograft in this situation. However, what is out there is actually quite promising, with survivorship reported similar to that of osteochondral allograft for other types of osteochondral defects. And also has significant improvement in patient-reported outcomes. So again, this is recommended as a first-line treatment with grade 2 evidence for large lesions, grade 3 to 4. Briefly, return to sport after cartilage procedures. About 76% return overall. Most common return to sport is osteochondral autograft transfer, followed by OCA and ACI. The important thing to remember in these studies are they're biased to smaller lesions, right? Because osteochondral autograft tend to be smaller lesions versus allograft is larger lesions. So I would not recommend treating a large lesion with osteochondral autograft in an athlete in order to increase the rate of return to sport. Sports subscores tend to do well. The osteochondral allograft, there's much less data on. What you'll see is microfracture does much poorly compared to these other treatment algorithms. Again, about 90% return to sport, 85 to 90% rate return to sport in a systematic review for the restorative procedures, and positive prognostic indicators are young patients with shorter symptom duration and smaller defects. So to summarize, couple large studies that compare these different treatment options. All cartilage repair met minimally clinically important difference at short and midterm follow-up, except for microfracture follows it starts to fail at midterm follow-up. Macy and Oates maintain improvements for 10 years. Again, this is limited by the data that we have, and this could very well change as we move forward. The one thing that I'll say with this study is the OCA did treat significantly larger lesions, which may explain some of the differences in their outcomes. As far as comparing Oates to microfracture and ACI, recent systematic review with more than 1 year follow-up shows that Oates was significantly better for return to sports compared to microfracture, and there's no big difference between Oates and ACI. Again, smaller lesions were good prognostic indicators. Another ACI versus mosaicoplasty, tissue histology was better in the osteochondral autograft versus ACI. There was a slower recovery. Now keep in mind this was second generation ACI, and clinical outcomes were superior, however, in the mosaicoplasty. It would be interesting to see going forward if we would see the same relationship with Macy, particularly given the early weight-bearing advantages. And again, a comparative meta-analysis with regard to reoperation outcome in tissue. Graft hypertrophy in second generation ACI and Macy is better than the first generation. We discussed this a little bit earlier. So to summarize, we've talked a lot about what to do about the lesions themselves. It's important to also address the comorbidities. Never forget, if you've got insufficient meniscus tissue, you're going to have increased contact pressures with progressive meniscus loss. So if you've got an insufficient meniscus, a meniscus transplant would be indicated. Malalignment more than 5 degrees. As you can see, as you deviate your mechanical axis, we're going to shift and increase contact pressure in the repaired compartment. This is going to decrease our level of success with cartilage repair, because remember, loading is healthy for cartilage, but when we have too high of loads, then we start to get an abnormal response. Finally, instability must be addressed as well, both ligamentous instability of ACL, PCL, MCL, and posterolateral corner, as well as patellar stability in the patellofemoral joint. We also want to consider why did the cartilage repair fail? Was it malalignment instability, meniscal insufficiency? Was it biology? Is the patient arthritic? Perhaps arthroplasty is the appropriate solution. Was it a technique issue? Was there inadequate subchondral bone and a cartilage-only procedure was done? So you need to significantly consider why these procedures fail before we go ahead and plan for a revision. And also remember, if you've got a failed microfracture and you've got abnormal subchondral bone, potentially an osteochondral solution is the appropriate treatment as opposed to something like MACI or ACI. So just a one-time review the algorithm one more time. Large defects versus small defects, chondral versus osteochondral are the important decision-making factors. Bottom line, my opinion, and this is what I do in my practice, you must correct the concomitant pathology. So osteotomy, if you've got malalignment, ligament reconstruction if you've got instability, meniscus transplant if you have an insufficient meniscus. You have to select the right patient, someone who's going to be compliant, someone who's a non-smoker, someone who has appropriate expectations. Small lesions do better for me. If they're active, they'll get an osteochondral autograft. If they're lower demand, potentially marrow stimulation. Small lesions, greater than 2 centimeters, I think ACI and MACI do better than microfracture, particularly active, high demand patients. Larger lesions for me are either MACI if the underlying subchondral plate is intact, or osteochondral allograft if it is not. Thank you. Any questions?
Thank you, Chris. Very comprehensive presentation. It's almost like a chapter on cartilage.
My pleasure.
Just a few questions. Sometimes when we do marrow stimulation, when you use a drill, you may see the fat globules coming out. So does that mean the subchondral bone is violated, and is it good or bad?
So we do. So we have to get into the subchondral bone in order to get the effusion of the marrow elements. So I think that's good. I think where we get into trouble, particularly if microfracture holes are too close to each other, or we have too large microfracture holes, or we start impacting the bone, as we actually change the underlying architecture. I think the advantage for me with drilling is it's much easier to make small holes that are located close to each other with surrounding good architecture. So you do want to see the marrow effusion. That's the desired effect of it. But my personal preference is drilling over impaction.
Thank you, Chris. Even I have preferred using drilling. The other question is, when you say chondral versus osteochondral, right? So in all our algorithms, it says chondral or osteochondral. So how do you define? Is it before you, with your MR and your X-rays, before going into that, you have to make a plan, right? Is it chondral or osteochondral?
Exactly. So I think for me, MR is certainly the most sensitive. If you have X-ray evidence, that's a very substantial lesion. You can oftentimes even see on small lesions, patients who have abnormalities of the subchondral bone. You just have to look at the lesions very carefully. One red flag that you've got abnormal subchondral bone architecture is marrow edema, although that's not mutually inclusive. You can have marrow edema with intact architecture, particularly in the context of an acute injury. But yes, MR or CT will show the subchondral bone architecture. And
do you get both MR and CT for all your patients, or just MR only?
I will very rarely only get a CT scan. I get almost only MR.
Thank you for that. I just want to clarify, because your lecture has been very comprehensive, and suppose someone wants to later on see. So I just want to make them very clear about the concepts. And you mentioned about contained versus uncontained defects. So how do you define contained and uncontained?
Good question. So a contained defect has 90-degree normal cartilage walls 100% of the way around. An uncontained defect is, say you've got a defect that's, adjacent to the notch, and there's no normal cartilage on that side of the lesion. So that would be an uncontained lesion. So those are much more difficult to manage. For me, I think those almost necessitate an osteochondral solution unless it's a small area where you have an uncontained lesion where you can tack it down with a suture anchor.
Thank you, Chris, for that. And when you use an allograft, what is the chance that it's going to get rejected? I mean, we talk about allograft rejection in other areas. What about the knee?
Yeah, so the literature on this is very, very sparse. There's a couple of studies out there that have suggested the rate of this is around 5%. I think it's difficult to determine why a graft fails. So, you know, when you see a failed graft, it can be due to a failure of vascularization of the graft. It could be due to rejection of the graft. It could be due to inappropriate fixation. So if it was meant to be press fit and you don't have a good press fit and there's too much motion and you've got a fusion of the synovial fluid around the graft. So there's a number of reasons why it can fail. And we haven't really figured out a good reason of graft rejection itself. We do know that pulsatile lavage, which is really the only technique that I'm aware of to try to eliminate as much of the marrow elements as you can from the graft, it doesn't do a sufficient job in eliminating all of the marrow elements. So it's certainly a risk.
Thank you, Chris. Just one last question before we wind up the session. In your practice, how do you, I mean, what is the percentage of, those who undergo microfracture, how many undergo ACI and how many undergo allograft or autograft? I mean, in a rough estimate, how is it in your clinical practice?
So I think that's always a hard question for me to answer because I think it's very patient specific. So if I've got an older patient who is lower demand, who, you know, they just want to be able to walk, you know, around and play with their kids and things like that, they're a better candidate for me for something like microfracture if they've got a small lesion. If I've got an 18-year-old athlete or an elite level athlete, we're certainly going to treat that much more aggressively. So I think it really depends on who the patient is. And I try to evaluate everybody individually. Now, gross numbers, I certainly do more microfracture alone or microfracture with something like one of these scaffolds than I do MACI or osteochondral allograft, because I think you want to identify the right patients who have, you know, a high demand, a large lesion, and a high chance of success of that type of a treatment, given the morbidity of doing a procedure like that, because often those are open incisions, and also the cost that those procedures generate. You know, that you don't want to necessarily treat patients just based on cost, but you don't want to be doing, you know, a MACI or an osteochondral allograft in a patient who has osteoarthritis either.
Thank you, Chris. I think that's all the questions that we have for the session. Fantastic lecture, very, very comprehensive. It's going to be a very good archive for those who want to watch it later. Thank you so much for joining me.
Perfect. Thank you so much for having me. It's been a pleasure.
Bye-bye.